Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and Opioids, sponsored by the Southeastern National TB Center. Today's speaker is Thomas Dobbs. Dr. Thomas Dobbs is an infectious disease physician trained at UAB and Wake Forest. He has been active as a TB public health physician since 1997, initially working with the Alabama Department of Health and Gorgas International TB Initiative. Dr. Dobbs has worked with the Mississippi State Department of Health since 2008 as District Health Officer, State Epidemiologist, and is the current Deputy State Health Officer. In August of 2018, he was appointed Interim State Health Officer beginning November 2018. Dr. Dobbs also serves as a clinical consultant with the Southeastern National TB Center from 2011 through July of 2018. Today's moderator is Connie Haley. Dr. Haley is an infectious disease physician trained at Vanderbilt University. She has worked in TB since 2001 and now works as a medical consultant for the SNTC. Now I will turn over to the presenter, Dr. Dobbs.
Hey, great. Welcome and good morning. Thank you all for attending this webinar, When TB is the Least of Their Worries. We'll cover a broad variety of topics related to opioids and also the intersection with tuberculosis. It's certainly been a tragic but fascinating event in our history, in the history of American public health. Probably will not require the entire hour to go through the material here. We'll try to make sure we have some time at the end for questions for people who need to go ahead and get back to their other work. So, please stick around. We'll try to make sure we have, really vigorous conversation afterwards as well. So, Connie, can everybody hear me fine, you think?
I can hear you, Thomas. Thank you so much for being willing to be our speaker today.
Well, let's go ahead and get started, and let's start off with a case. So we'll give a nice little story about the intersection of tuberculosis and opioids. We'll start with the 55-year-old male who has a history of coronary artery disease, long history of smoking, and he has a history of chronic neck pain. He's had some sort of injury that required surgery with hardware placement. He goes to a chronic pain physician and takes daily doses of hydrocodone, 10 milligrams 4 times a day. He works offshore on an oil rig. Over the course of a year, he developed progressively worsening dyspnea. This was associated with cough. And he was admitted to a hospital in Alabama in May with respiratory failure and required prolonged ventilation. On admission, he had a white blood cell count of 47,600, elevated platelet count at 572,000, and a markedly elevated lactic acid. In the course of evaluation, he was found to have a positive AFB smear from BAL on May 14th. On the 16th of May, he was started on 4-drug TB therapy, and on the 25th, he was culture positive for tuberculosis. It's curious that he had such abnormal lab reports from his admission and respiratory failure, which is not something we routinely see with tuberculosis. There was no evidence of another type of pneumonia that was going along with tuberculosis, but clearly had advanced disease that was visible on chest x-rays going back a year and unfortunately had been missed at previous opportunities to likely diagnose active tuberculosis. In July 2011, he was discharged home continuing tuberculosis medications. He's found to have pan-susceptible disease and ethambutol was discontinued. On July 13th, he was still, however, 2+ smear positive. He was at home now, and toward the end of July, he ran out of pain medications. He had been off of them for 1 week, and the pain physician who had been seeing refused to refill them. And the reasons he refused to fill them were severalfold. He refused to let the patient come to the clinic because he was concerned about him being contagious, and he had been on treatment for a couple of months already, but still was smear positive, and we had not had evidence of culture conversion at this time. But the other thing that was problematic is he refused to call in a prescription or to send in you can't really call in a prescription now for Lortab. You have to get a written prescription. And he was unable to get that sent in due to or he would refuse to send it in because of the regulations that now exist in Mississippi for prescriptions. The Board of Medical Licensure in Mississippi had passed some rules around opioid prescribing that are similar to many other states. Every state has its own internal rule keeping. Some of it's going to be law and some of it's going to be through the Board of Medical Licensure. But there are several things that where a pain clinic, you had to come in and get your medications every month. You had to have a urine drug screen regularly performed, and the physician had to check the prescription monitoring program, which we'll talk about a little bit. So now we have a guy who has TB. We're taking care of him. He's off of pain medicines for a week, and he's complaining of pain, and we've got to figure out what to do for him. And we'll answer that question later on in our talk. And since this is a tuberculosis lecture, we can't not have a chest X-ray, at least one. Now, this is a chest X-ray of this gentleman. This is actually at the time period around July when he was back home in Mississippi. And you can see that he has apical, biapical infiltrates scattered throughout both lung fields. But you'll have to take my word for it that this is a significant improvement over the X-rays that he had when he was hospitalized. So today, let me go over the agenda real quickly. We'll go over basically the essential elements of the opioid crisis and how it unfolded. We'll talk about identifying patients at risk for opioid abuse and dependency. We'll talk about opioid abuse and risk of tuberculosis, management issues that are associated with opioids and tuberculosis, potential drug-drug interactions with opioids, and also too with MAT, which stands for medication-assisted treatment. And we'll talk about resources for physicians and patients facing addiction and dependency issues. It'll be a little bit different than some of our TB talks because it won't be necessarily solely TB focused, but we really want to talk a little bit about this whole universe of opioids and our response to it, because it's going to be very important for certain patients that we interact with, both with latent tuberculosis infection and also with active disease. So what's the impact of the opioid crisis? It's really been pretty remarkable. And in my mind, and this is going to sound kind of preposterous, I think it's really the biggest public health crisis of my generation. And one of my main things that I do as a clinician is HIV care, and have been doing that since 1996. But actually, I think that this is actually a bigger crisis than even the HIV crisis. From 1999 to 2016, we've had more than 630,000 people have died from drug overdoses, and 2/3 of those have involved opioids. In 2017, there were 72,000 deaths from overdoses, and about 50,000 of those were associated with opioids. And if we think about that in context, if we think about all the people who died during the Vietnam War, which was a horrific tragedy, all the deaths that occurred, every year we're basically racking up a Vietnam era's worth of deaths from opioid overdoses. That kind of gives us some perspective about really what's going on. And that doesn't really even remotely speak to the impact of opioids as it pertains to patients' livelihood, well-being, addiction issues, productivity, the effect on the families. It's really, that's just the tip of the iceberg if we consider all the things that it impacts. On average, 115 Americans die every single day from opioid overdose, and over a $95 billion economic impact in 2016. So again, it's really a pretty remarkable impact. So how did all this come to pass? Well, over the past couple of decades, we've seen a remarkable increase in opioid sales. And you can see this in the green line here on top. And this is in kilograms, 10,000s of kilograms. And then you can see that we have increased really remarkably since the 90s. And along with that, not surprisingly, we see a steady increase in the number of opioid deaths and opioid treatment admissions. Let's look at another slide that shows the impact of opioids. And if we go back to 2000, you can see that we were seeing a significant number of opioid deaths at about 3 per 100,000. But over the years, we saw in this purple line, this is going to be our natural and semi-synthetic opioids. This is going to be what we consider typically our prescription opioids. We started seeing a significant increase of overdose deaths associated with that. And this is going to be like the Oxycontin and Opana and that sort of thing. People dying from that, again, sort of consistent with this rate of increased prescribing that we saw over this decade. But then as we get to around 2010, we started seeing a marked increase in heroin use. and heroin use started spiking. But then in 2013, then we started seeing these other synthetic opioids like fentanyl, where people are overdosing with that in alarming frequency. People using injection opioids, not really sure what the mix of heroin is, or fentanyl. And fentanyl, which is far more powerful than heroin, caused a lot more unintentional deaths in people who didn't really know the potency of the opioid that they were using. There's been a significant amount of debate about why we did have this transition from utilization of prescription opioids into synthetic opioids. Some of the suggestion has been that because synthetic or our prescription opioids are harder to obtain, people have switched over to heroin and fentanyl. But there are a lot of components to that, and probably some of its economics, in that at this time heroin and the synthetic opioids became far less expensive. So for people who are abusing these through IV means, the natural and semi-synthetic opioids, there was an economic transition to using fentanyl, although we still have significant concern about people, particularly abusers, who are using the prescription opioids, transitioning over to heroin and fentanyl as we try to restrict the flow of prescription opioids into the community. One of the most remarkable demographic shifts that we've seen related to this has been the increase in all-cause mortality. Unlike really any other event we've seen in the history of public health, the opioid crisis has resulted in increased all-cause mortality in American citizens, and particularly in the age group of white males aged 45 to 54. And if you look at this graph here, around 2000, right when the opioid stuff started really kicking in, we started an increase in the mortality rate of white males in this age group. And the only other thing I can really kind of give corollary to on this would be, at the fall of the Soviet Union, we did see a similar spike in all-cause mortality in the Russian population related to alcohol consumption, and sort of like the economic sort of despair that was present there. There's been a lot of discussion about how the 2008 economic crisis and the recession certainly drove some of these deaths of despair, people who didn't have access to good jobs, and depression and that whole sort of thing. But as we see clearly, around 2000, even when the economy was doing quite well, we started seeing this increase in all-cause mortality, driven in large measure by opioids, but also in some of the associated sort of issues: alcohol, liver disease, and cirrhosis. Let's talk a little bit about opioids' grip on Americans. In the United States, 11.8 million people are abusing opioids, or about 4.4% of the population. Going back to the previous concept of the number of deaths, I'm sorry I didn't share you with that. There has been a marked increase in the percent of all deaths in the United States attributed to opioids. So in 2001, 0.4% of all deaths were attributed to opioids. In 2016, 1.5% of all deaths in the United States were attributed to opioids. So look again at people who are misusing opioids. 11.5 million are misusing prescription pain relievers. That's going to be 97.4% of opioid users. About 948,000 heroin users, about 8%, and then 641,000 who are using a combination of heroin and also prescription painkillers. So it's a pretty common problem in our population. So what got us here? And we'll dig in on a couple of these different topics, but really it's been a combination of things. It was a mix of bad science in the 80s and 90s. We relied on some science that really was not well founded. Advocacy groups trying to get more pain medication to people in need. This was fed upon by the greed of big pharma trying to sell drugs, and the story of Oxycontin is going to be a big part of that. We add into this what I say is a complicit medical system, that we accepted not only the science without really critical thinking, but also the sales pitches of big pharma, and basically bought it kind of hook, line, and sinker to some degree. The Joint Commission, who does accreditation for hospitals, we'll talk about them a little bit, but they were big proponents of this, patient-centered, subjective measure pain response treatment plans. And then Center for Medicare and Medicaid Services played a role with the fifth vital sign and using that for patient satisfaction, star rating, and also reimbursements. And then we throw into this the upsurge in heroin in synthetic opioids, and then we have a group of people who are addicted and dependent upon these prescription opioids, and it was like pouring kerosene on a fire, and everything kind of went wild. So real quickly, let's just talk a little story about how some of this stuff got started. You may be familiar with a gentleman by the name of Arthur Sackler, physician, a marketing executive who abandoned practice early in his career, made a fortune early on marketing Librium and Valium. He established the medical newspaper, the Medical Tribune, as a venue to market drugs, and kind of, I guess, like the father of throwaway journals for the purpose of for advertisements, but also too was an early pioneer of pharmaceutical marketing, and pretty much also the father of what we think about our drug reps. You know, people come around trying to get us to use stuff for their profit motive. A little bit more about the Sackler family. There were several Sackler brothers, physicians, and in 1952, they bought a small pharmaceutical company that made laxatives and earwax treatment by the name of Purdue Frederick. Purdue Pharma, which was later changed the name to, made great profits off Oxycontin. But in the mid-1980s, Oxycontin patent was expiring. Oxycontin was a powerful, long-acting form of morphine that I can remember using early in my career, but really it was marketed primarily for use in terminal patients with terminal pain and terminal cancer, and seemed to work quite well. But it was expiring, and they wanted to, you know, transition their profits to a different venue. So they decided to pursue a long-acting oxycodone, which ended up being Oxycontin. Oxycodone was extremely cheap to produce, and if they could put it in a format that did slow release, it would be a pretty good exchange for their Oxycontin product. But they produced it in dose ranges of 10 milligrams to 160 milligrams. To give you guys some context, oxycodone, contrary to many people's understanding, is 50% more potent by milligram than morphine. And so if we look at what these doses are, and these are BID dosings, keep in mind, for Oxycontin, this is going to be essentially 15 milligrams of morphine twice a day. In this dosing, that's going to be basically 240 milligrams worth of morphine in a single pill. How incredibly potent that is. Just to give you some context to what the maximum recommended doses are, the CDC guidelines for chronic pain treatment recommend no more than 50 morphine milligram equivalents. So that would be essentially, if you gave this one, 2 pills twice a day, that's going to be 30. That's going to be 60 milligrams morphine equivalent in that one dose. And up here, you're going to be way over the maximum recommended of 90 morphine milligram equivalents daily. There's a gentleman by the name of Russell Portenoy who in 1986 published an article called The Chronic Use of Opioid Analgesics in Non-Malignant Pain. It was a report of 38 cases. And from this study, he and his another author recommended opioid maintenance therapy for chronic pain. It was essentially a glorified case series that, based on just 38 patients who didn't have really bad outcomes over a modest period of observation, used this as a tool to advocate for the chronic widespread use of opioids for non-cancer, non-terminal pain. Curiously, I use this article for my epidemiology students. I teach in grad school and have them do an in-depth sort of critique of it. And it's kind of remarkable that we use this sort of data to drive some of our decision making around something so potent and scary. This gentleman, Dr. Portenoy, has now changed his mind and thinks that the whole opioids for chronic pain was a huge mistake, and that and acknowledges to some degree his role in advancing the opioid crisis. So what about Oxycontin? What happened with that? In 1996-2001, Purdue trained greater than 5,000 physicians and other professionals for speakers, and so they went out trying to sell this drug to use for pain treatment. But what they did that was revolutionary but also terribly frightening is, instead of targeting oncologists and people like hospice providers and things like that, they targeted the primary care physicians to use routinely for chronic non-cancer pain. And they had these flashy ad campaigns, as you probably remember, "I got my life back," that sort of thing, saying that this is entirely safe to use. And they had a very aggressive marketing, making some claims that were really based on no science, that there was no risk of addiction from using this drug. There's some other things about Oxycontin that made it particularly dangerous. It wasn't really a 12-hour dosing formulation, so people had a lot of difficulty in the periods between doses with withdrawal symptoms. And then in the 1990s, there was this thing called the fifth vital sign, and most physicians providers that I work with are not big fans of the fifth vital sign. Basically, it's a subjective measure of what a patient thinks their pain is, and it can be used if patients say they have a high score, that they're uncontrolled. There can be punitive findings for hospitals, particularly as it relates to the Joint Commission and CMS accreditation. In 2001, the Joint Commission, which is again accredits most hospitals in the United States, established the fifth vital sign as an essential component of the patient assessment. And then Center for Medicare and Medicaid Services adopted the pain control measure as a component of quality-based reimbursing, the star rating that hospitals get, and also two reimbursement components. So now we have this fifth vital sign and patient satisfaction for pain control as a driver of hospital activities, again making it easier to pump a lot of pain medications into our patient population. Here we see the book that was published and submitted to hospitals by the Joint Commission, Current Understanding and Assessment, Management, and Treatment of Pain. Basically was the guidebook they wanted hospitals to use for managing pain. Curiously, it was written in conjunction with the National Pharmaceutical Council, which you can imagine that their vested interest would be to make sure that we use as much of their medications as possible. It's an interesting read. If you're interested in this topic, I would encourage you to get a copy and flip through it. It has some kind of preposterous things in there. Here there is no significant evidence that addiction is a significant issue when persons are given opioids for pain control. There was no proof that didn't happen, but there was not adequate studies, and so that was taken. The absence of a finding was pursued as an excuse to go ahead and use pain medications unrelentingly. And I can remember when I was in training, and probably a lot of you guys are my age group in the mid 90s, we had the pain teams and people come around saying that we're underusing pain and pain medications and they're really not addictive like we think we are. And certainly it seemed kind of preposterous to a lot of us who'd been taking care of people who had chronic pain issues that were very legitimate, particularly like in the sickle cell unit where you had, wonderful patients with horrible pain, but also horrible dependency issues because we've been having to give it pain medications for so many years, and they did have legitimate pain issues. If you have any interest in reading more, there's a fascinating article in the New Yorker called "The Family That Built an Empire of Pain," and this talks about the Sackler family and the history of Oxycontin and their interplay both with the Joint Commission and also with the FDA to get Oxycontin on the streets, and probably one of the biggest drivers of the opioids of all the different components. So we're going to kind of change gears a little bit. Let's talk a little bit about identifying patients at risk for opioids. We'll talk about the demographics of patients that are at highest risk. There are geographic variations, and certainly prescription drug monitoring program is a way to identify patients who are using opioids inappropriately. So, kind of real basic risk factors for opioid abuse and overdose are going to be rural residents, low income, history of mental illness, prior drug or alcohol use, and history of pain syndromes. In our own internal research in the state of Mississippi, we found that rural white males who have high school or less education and are single or divorced are by far the most likely to die from an overdose, kind of fitting into the national picture that we see in total. Now, going back to the history of chronic pain syndromes, I would like to say that it's really kind of chronic musculoskeletal pain and back pain for which opioids have been shown to have really no benefit. New studies have shown that compared with Tylenol, NSAIDs, or opioids, there really is no therapeutic benefit of opioids when treating these syndromes. When looking at data about, however, cancer, people who have cancer or terminal pain are not likely to abuse or be hospitalized with secondary bad outcomes, which is reassuring because we certainly do want to make sure that we have opioids for people who desperately need them. Risk factors for heroin use: Caucasian, less than 20,000 annual income, Medicaid or uninsured, age range 18 to 25. and prior history of prescription opioid abuse, 40 times greater risk for heroin if they have abused opioids. The majority of people who use heroin in the United States today started off abusing prescription opioids, not necessarily even from getting from their doctor all they could, but they could have bought them off the street. And we are seeing an increasing use of heroin in women in higher incomes. And as I mentioned, currently heroin and fentanyl are so much less expensive than prescription opioids that there's economic pressure having people switch from prescription opioids to these dangerous injection opioids. If we look at the opioid prescription rates in the United States from CDC data, we can see there's wide variation. There's certainly a very significant concentration in sort of the middle section of the United States, in the Southeast. In Mississippi, we have the 4th highest rate of opioid prescribing in the country, and we are surrounded by the top 3, Alabama, Tennessee, and Arkansas. So we're kind of in the eye of the storm, and Louisiana is not far behind us. So I just want to mention a little bit about the prescription drug monitoring program. Some of you guys may have some significant familiarity with this. These prescription monitoring programs, or PDMPs, people often call them, are basically mechanisms for state government licensing authorities to have data on prescribing patterns within the state. And how it works is, in most instances, pharmacies will submit to a central database the patient's demographic information, name, address, date of birth, gender, and additional data, the license number of the pharmacy, and also of the physician, DEA number, and drug information. So basically, they're cataloging all the information on a prescription for a controlled substance that a patient gets at the pharmacy, and this goes to a central database. And there's several things you can do with this. You can monitor trends, and this is where a lot of the information comes from to see what opioid prescribing trends are. But it also allows physicians, when a patient comes in for care, to access this PDMP and see what their prescribing history has been, and then they can make a decision about, is the person abusing, are they doctor shopping, or are they taking other medications such as benzodiazepines that may be very dangerous to use in combination with opioids. Most states do have prescription drug monitoring programs, or PMP is a common acronym as well. Only parts of Missouri, according to this CDC map, or I'm sorry, this National Alliance map, does not have a comprehensive PMP. And many states mandate the use of PMPs. There's different rules about this, but in Mississippi, just as an example, it's mandated that a prescriber check the PMP before giving a controlled substance, opioids, or benzodiazepines, also amphetamine type stimulants, to make sure that there hasn't been an abuse history, or there might be other drugs that people are taking that would make them dangerous. But it varies a lot by state, whether it's mandatory or what other sort of incentives are in place for people to check this information. All right, so again, just want to ask, let's go ahead and ask a question and get some feedback from our attendees. Does your state mandate PDMP checks before prescribing opioid analgesics? Go ahead and answer that question, and I'll give you guys a minute, 1 minute exactly, and then we'll tally the results. Well, it's only been 30 seconds, but I think everybody has pretty much entered. It looks like we have about 59–60% of respondents state that the state does require checking the PDMP, and this has become a lot more common. 9% do not know, 31% do not know, and 9% say no. It's becoming more and more common, and just anecdotally, you'll learn remarkable things about patients when you look and see what they've been doing. It doesn't necessarily mean that there's anything sort of devious or surreptitious about their activities, but it's really important to understand what patients' prescribing history is when they come in to get these potent and dangerous drugs. All right, next question. Let's ask a question. Have you personally accessed a state-sponsored PDMP? And we'll go ahead and start that poll. Oh, great. So it looks like, we can go and close the poll, I think. It looks like 10% said yes and 90% say no. And so for TB providers and people in public health, that certainly makes sense. I have rarely had to check it because most of my work does not involve use of controlled substances, but certainly have accessed it from time to time. But I'm glad I'm bringing it up because maybe you guys are not as familiar with this, but it's certainly going to be an extremely important tool going forward as we do, surveillance and monitoring of the opioid epidemic from a public health perspective. But it's also a tool that physicians can use to, better understand what's going on with their patients. All right, so let's just go back to our case and let's talk about our guy. Our TB case we talked about before, RM on 5/16, as you remember, he was started on 4-drug TB treatment. On the 13th, he was still 2+ smear positive. On the 20th, he ran out of pain medications, and his pain physician would not see him. So they wouldn't see him again because he was afraid he would spread tuberculosis disease. And due to regulations, the patient must get a new prescription every month. So I'm going to ask you guys a question. So what would you do at this point? So he's a guy in your clinic, and you have several choices. You can prescribe the opioid analgesia yourself. You could call the pain clinic and ask them to be allowed to visit wearing a surgical mask. Call the pain clinic and ask for an emergency prescription to assist in the interval, or allow the patient to continue off pain medications, or would you do something else? All right, I think our poll has kind of settled down. It looks like the majority of people would have called the pain clinic and asked them to allow to visit with a surgical mask, and that was something that we had looked at doing, but the clinic was still reluctant to do anything. I put other on there, but I wish I had an ability to know what the other was if anyone had something sort of innovative to do. If we talk about prescribing the opioid analgesia yourself, no one wanted to do that, and I think that's a good idea. Pain clinics typically want to manage all the pain medication, and there are certain restrictions about that if people are engaged, so you could actually undermine the patient's care plan. I think number 2 is a great answer. 3 is a great answer too. But number 4 is actually what we did because he'd already been off of it for a week, and it wasn't entirely clear to you from the information I gave you, but he wasn't feeling that bad. And so we decided just to monitor him off of medications. And 2 weeks later, he was doing well off of medications. And I was actually hopeful that he would go ahead and back off the chronic opioid use. But once he was culture negative, the clinic allowed him to come back and get back on medications. There's a clear benefit of being off chronic narcotics if you can help it. There is a concept of hyperalgesia that goes along with taking pain medications, where you basically upregulate the pain receptors, and if you stop the pain medications or wean off, which would be a better approach, you actually don't feel worse because there's an adverse event from the pain medications themselves. And so I was hoping he could stay off, but alas, he wanted to get back on them, and certainly we didn't interfere with that. So let's talk a little bit about opioid abuse and the risk of tuberculosis, because there is an interplay between the two where we can have problems with with TB among our opioid abusers. 18.7% of TB patients in the U.S. report substance use disorder. If you're a U.S.-born patient, there's a 1/3 chance that you would have a substance abuse disorder. People who have substance abuse disorders or opioid abuse are more likely to be smear positive, and they're more likely to experience treatment failure. Men with an odds ratio of 1.4, and curiously for women even higher at 2.4 odds ratio. And also more likely to be associated with county level genotype cluster, which is not entirely surprising because if you have abuse issues or opioid abuse, certainly that is often associated with socioeconomic circumstances that may make it less likely to get prompt care or even to seek treatment promptly. If we talk about IV drug abuse and tuberculosis, the IV drug abuse rate, the TBI rate or latent TB rate among people with IV drug use is pretty high and can vary anywhere from 10 to 39% in various areas across the United States. The duration of IV drug use and older age is the strongest predictor of latent TB. We also know that opioids have documented immunosuppressive effects, although it's not clear what impact that would have on tuberculosis, but there would be concern that they might be more likely to progress on to active disease. Drug use is also frequently associated with other risk factors that make people more likely to have tuberculosis, but also have treatment issues, including tobacco abuse, homelessness, alcohol abuse, and incarceration. If we talk about IV drug abuse and TB treatment, people who are IV drug abusers are more likely to present later for diagnosis, increasing the risk of subsequent transmission. The opioids have a capacity to suppress the cough reflex, and so the decreased cough may delay presentation. It's associated with poor health literacy, which is not entirely surprising, and there's a higher risk of not completing TB treatment with an odds ratio of 5.7 in one study. And if we think about the different elements of substance abuse and how it relates to TB control, I'll go through this pretty quickly, but substance abuse associated with smear-positive disease. When we talk about diagnosing folks, patients abuse substances are more often unwilling to unable to recall names or contacts, so it will impair the contact investigation. More difficult to locate and less likely to get screened for TB if you are a contact, and contacts who abuse substances are less likely to initiate, adhere, or complete latent TB treatment. So there's a whole cascade of issues in addition to the TB treatment, but also TB control when we talk about the interface of tuberculosis control, tuberculosis treatment, and substance abuse, opioid abuse. And if we talk about IV drug abuse and latent TB, we have improved completion rates for latent TB if we use directly observed therapy incentives. And if we can incorporate it with substance abuse treatments, such as people who go to methadone clinics every day, certainly that's a good way to catch somebody when they have to go somewhere every day to get their maintenance supply of opioid. And not surprisingly, if we do treat people for tuberculosis or latent TB, there's an elevated risk of alcohol abuse, elevated risk of HIV and Hep C, and associated with those, there can be a 4 to 5 fold increase of drug-induced hepatitis for people who have HIV or Hep C, and if you have both, there's a 14-fold increase risk of drug-induced hepatitis. So we got to be extra careful when we monitor people with liver disease when they're on TB treatment, which is not surprising. So we'll go on to another case. We have a lady, TJ. She's a 45-year-old female with rheumatoid arthritis. She takes hydrocodone 5 milligrams TID, has a positive quantiferon when she's getting screened for a biologic treatment. She has a normal chest X-ray, no clinical symptoms of tuberculosis, a normal liver function, and a normal CBC. So the question I was going to ask you guys is, how would you treat this patient for latent TB infection? Would you treat her with 3-HP weekly? Would you treat her with isoniazid times 9 months, as there's no significant drug-drug interactions with hydrocodone? Would you give her rifampin for 4 months, or would you have the patient wean off the hydrocodone prior to starting latent TB treatment? Oh, sorry. I think we've settled out. I think we can close the poll now. So it looks like we had kind of a split between 3-HP and 9 months of isoniazid. 21% chose rifampin for 4 months. And then we had 11% would wean the patient off hydrocodone, and none of them wrong answers. We had, in this example, we had thought about doing 3-HP, but declined because of scheduling issues, and we haven't moved on to self-administered 3-HP in Mississippi yet. We did do the rifampin for 4 months, and then contacted the primary physician to be aware of potential drug interactions in case there needed to be a dosing adjustment in her chronic pain medication. So let's talk a little about managing drug interactions, and this is going to be one of the primary concerns when we're talking about treating people for tuberculosis or latent TB if they're on chronic opioids. We know that rifamycins are potent inducers of the P450 enzyme system, especially CYP3A4. Rifampin is the most potent. Rifapentine is about 85% as potent as rifampin, and then rifabutin is not as much, but still has about as 40% induction capacity as rifampin does. If we talk about using prescription opioids along with rifamycins, we may need to increase the dose when we use rifamycins. We have to be careful to reduce the dose after we stop the rifamycins because we don't want the blood levels of the opioid to accumulate following the stop. But it does take several weeks for full normalization of the P450 system after we stop the rifamycins, and so a steady and slow decrease in the dosing may be called for because of that delayed resumption of activity. Methadone, certainly administration of rifampin or rifapentine may necessitate increased doses of methadone. Again, certain to reduce methadone dose once rifamycin is discontinued. Monitor for withdrawal symptoms if we use with rifabutin. It may not be enough to really be clinically significant, but certainly monitoring is needed. And methadone is going to be used, sometimes it's used for chronic pain. It's extremely dangerous because it does have such a long half-life. The most common utilization of methadone is going to be for harm reduction treatment for people who are addicted to opioids, to take a daily dose to suppress cravings and abuse potential. So buprenorphine, let's talk a little bit about buprenorphine. It's a partial opioid agonist. It has a lower ceiling effect in that if you take more and more of it, it doesn't really give you the high you would get if you take other opioids. It's actually used as maintenance therapy for people who are opioid abusers, such that they can not have the withdrawal symptoms, and also to affect their brain chemistry in a way that they don't abuse. It often is taken together with naloxone as the brand name Suboxone. And one of the reasons it's put in this formulation is it diminishes the capacity for diversion IV drug use. Naloxone, if you take it orally, is minimally absorbed, and then the buprenorphine can hit the opioid receptor and it gives it effect. But if you take it intravenously, it will, the naloxone is supposed to block the opioid receptor, so basically it would be kind of a negative effect. But I will say that just recently I had a guy come in with endocarditis who'd been shooting up Suboxone, so people can still, these guys are pretty innovative and can get a high off it if they want to. It was approved as MAT, or medication-assisted treatment for opioid addiction, in 2002. Unlike methadone, it can be prescribed in a physician's office, and you can kind of use it as home, kind of like a regular medication. Buprenorphine comes in several formats. It comes as Abunavail, Suboxone, Subsolve, transmucosal products. There is an IM, a monthly injection that's kind of exciting. You just come in once a month and get it, and it has slow release. And also there's a 6-month implant. None of these things are cheap. And sort of ironically, Purdue Pharma has just patented a new transdermal formulation. So now they're going to try to make money off of some of the issues that they caused. To prescribe buprenorphine products, you have to get a thing called a data waiver from SAMHSA, which is the Substance Abuse Mental Health Services Administration. And basically, it's additional training that allows you to prescribe these medications. The only thing is it's restricted to the number of patients that you can do. I think it's like 70 to start with, but you can apply for an allowance to do more patients to treat with addictions. It can be used for acute withdrawal symptoms, not for more than a 72-hour period, and 1 day's medication may be administered at a time. Some ERs are experimenting with this as a way to treat people who come in with drug overdose, to try to get them temporarily treated for withdrawal, and also as a bridge to get them into chronic treatment. Buprenorphine is a CYP3A inhibitor. You may need to increase the dose, when you give it with rifamycins, and again, decrease the dose following the completion of rifamycins. So the efficacy, they're not perfect. About 50% retention rate for methadone at 20 weeks, and buprenorphine about 40% improved response over detox alone. But it is recommended that MAT, methadone, or buprenorphine are used in conjunction with psychosocial treatments. If you guys have friends who are in opioid addiction work, they'll tell you that people come in for rehab and it's just so hard. Their failure rate is just remarkably high, and it takes numerous admissions to get them over it. And a lot of times they really can only do it with combination medication-assisted treatment. And that's one of the reasons why this is a big strategy promoted by CDC and SAMHSA. So syringe services programs are another mechanism to provide free sterile syringes, safe disposal to help people who are, harm reduction for abuse. Provide other health and supportive services are a part of this. Certainly want to do comprehensive risk reduction, HIV, hepatitis screening and referral, substance use treatment, and other medical referrals as needed. And these are not universally available, but they are known to decrease new HIV seroconversions, increase referral and retention to substance abuse treatment, and then improve access to health services. And these are the states with active syringe programs in 2018. A lot of states do not have active programs, but this may be something that's more and more common as we're seeing the onslaught of more and more IV drug abuse. Let's talk a little bit about resources for physicians. If you want to read more, SAMHSA's website, samhsa.gov, is a great resource. There is a National Directory of Mental Health Treatment Facilities. So if you want to find somewhere that someone's need referral, you can go to this website from SAMHSA again and can give you a directory of places that you can refer your patients if they need any help. Certainly your state Department of Mental Health is going to have a lot of resources. And then the American Society of Addiction Management is another great resource with all sorts of information and resources to help. CDC does have opioid treatment guidelines. If you're not familiar with it, it's kind of one of the guiding forces of opioid treatment. There's several components. A lot of it is to, not use opioids if you can help it. Start low and go slow. Treat with opioids only for short periods of time. Data has shown it's not the dose of opioids you use so much as the duration. And the longer that you use an opioid, even if at a modest dose, you're markedly increasing the chance that they'll be using it a year from now. Using short-acting opioids is preferred over long-acting. They want you to check the PDMP at least every 3 months, and certainly there's different rules for different prescribers in different states. Certainly don't want to use opioids with benzodiazepines. A lot of the deaths are associated with both these drugs, and they potentiate each other in the overdose potential. Checking urine drug screens is an important component. And then also using medication-assisted therapy and behavioral treatments as you can for people who are addicted. For patients, there are a lot of resources potentially available too. There's a substance abuse health line that is supported by SAMHSA. You can see 1-800-662-HELP. The Buprenorphine treatment locator. You can find places where you basically have MAT clinics where people can go. There haven't been enough of these for people who need medication-assisted treatment, but there's a lot of effort now to expand this as part of the federal response. A lot of states are receiving grant money to support the provision of MAT through community mental health centers and other providers. So hopefully that's going to be something that's going to be more and more available for people in need. And there's also an overdose prevention toolkit here for people who might be at risk of overdose. Real quickly, I just want to touch on naloxone. Have you guys some familiarity with it? From 1996 to 2014, there were at least 26,500 overdoses reversed by laypersons using naloxone. Laypersons, mind you. It can be used by medical personnel, first responders, or even friends of opioid abusers. It's pretty easy to use, particularly in the nasal spray format. There are programs to distribute naloxone to abusers and family and friends, and it has been shown to decrease overdose death, and it can be given in multiple formats. Again, the nasal spray is the most convenient, but there again, there's a cost to it. As far as using naloxone, most states have a Good Samaritan law so that a bystander could use it without risk of sort of criminal prosecution if something went awry. There's really nothing bad that can happen from naloxone. I mean, the worst thing that's going to happen is it's going to make them feel withdrawal symptoms, but it's going to save their life. So there aren't really many potential side effects from naloxone. It's pretty safe. And most states allow for standing orders for pharmacies to distribute naloxone without a specific prescription. So basically, a standing order would be that a pharmacy has a standing order from maybe even the state health officer or from a physician. It's not universal that pharmacies have these, but they can. And then someone comes in and say, I want some naloxone, and they can just get it without having to have made a medical visit. Although certainly you can get a prescription for naloxone from your provider if that's needed. And you can see here where the Good Samaritan laws are, where laypersons would be immune from criminal liability if they had administered naloxone. Most states do have that in place. Not all. If you're wanting to know, I recommend you kind of looking locally. Maybe ask your state health department. Will probably have a better awareness of this. And if we talk about places that have standing orders where you can get naloxone without a patient-specific order, most states in the country obviously have access to that. So certainly naloxone is a good way to prevent death from acute overdose, but certainly that does nothing to prevent future overdoses and doesn't treat the addiction itself. This is a slide that I love. Around the turn of the century, Bayer came up with this fantastic new product to treat everything that ailed you that was less addictive than morphine and had few side effects. And its name was Heroin. And remarkably, you can see here in this commercial where they have a bottle of heroin on the kitchen table for your kids to take. And actually, this use of heroin and sort of the ensuing sort of adverse events that came from the opioid use in the 1920s and before that led to some of our early federal regulations restricting the use of opioids, realizing it was a public health disaster. Unfortunately, sometimes we don't learn the lessons of the past, and now it seems like we are repeating some of those issues. So that is the last slide that I have. It is now 11:50, so we are right on time, and we can go ahead and Connie, do we have any questions?
Hey, Thomas, thank you so much. That was truly a wonderful presentation. I always learn so much from you, and I think certainly this is a huge topic in our practice for tuberculosis, as it is for people in any practice anywhere. I do see some questions. One of the questions that I see has to do with PDMP programs, and the question is, who can access a PDMP and how, for example, if you were a case manager or a clinic nurse, someone taking care of your patient, how would you look to see if your state has a PDMP, and how would you go about looking up a specific patient?
That's a fantastic question. It's going to vary state by state, but typically, if you want to look at a specific patient, you have to register with the PDMP. And so it may well be, now the rules may be different state to state, but there was a map that showed that the states had PDMPs, and most of them will have one. So if you just look it up online, a lot of them are managed by the medical licensure. Ours is managed by the Board of Pharmacy. Some can be managed by the state health department. But you typically have to register, and then you would send in your credentials, and then you would have online access to the PDMP data. You may have to have a licensed provider, nurse practitioner, or physician to do it, but most states, and I know our state does, allows for a delegation of authority to the nurses as well, so that nurses can have access to that. But it's going to vary state by state, but pretty much would have to register with your state program.
Thank you. That's good to know. Very useful information. Another comment really came up when you were talking about drug-drug interactions and how important it is for us in our practice to be aware that we've got a patient who's either on prescribed opioids or maybe using illicit opioids, starts rifamycin, and then all of a sudden, starting to have more pain or start to get some withdrawal. Can you talk a little bit more or cover again what you do for your patients who are taking opioids at the time that you need to start TB therapy for active disease, and then a little more about how you do you adjust the doses? Do you use drug levels, therapeutic drug monitoring during your treatment?
Yeah, that's a great question. I'm not familiar with using therapeutic drug monitoring for the opioids. All that may be available, I'm not familiar with it. A lot of it's going to be sort of clinical monitoring and close evaluation. It's pretty rapid, the induction of the P450 system by rifampin, and so you'll notice an effect quickly. A lot of it's going to be just your management strategy. We typically and would recommend getting on early on, even before starting treatment with the primary physician, so that they're aware of this and will not think that the patient is trying to abuse, and do slow dose escalations until the patient has some symptom relief. There's not much data on sort of like what amount of increase you would have to do. I think it's going to be somewhat of a judgment call, a clinical call as you sort of escalate it. But I would, go low and go slow would certainly be what to do. It's more difficult with the heroin though, because they may be using it periodically, and they may not receive the high that they want to receive, and might end up using more. It's just really difficult to know, and it's really kind of touch and go adjust as you move along, sort of scenario. And again, close integrated work with the primary care physician, unless you are the primary care physician, to make sure that you can adjust those things as needed.
Yeah, thank you. And we've also used, although theoretically opioids don't cause much of a decrease in rifampin, they do have a more profound influence if you're using rifabutin. And so we do sometimes use therapeutic drug monitoring for the TB drugs, the rifampin or the other rifamycins, just to make sure patients are getting enough of their TB drugs, especially when rifabutin is used instead. And then just, again, the warning that patients who are taking TB therapy and then TB therapy stops, or LTBI therapy if a rifamycin is used, there's an increased risk of overdose. And so be sure that patients, you talk with your patients about what do you do with their opioids after you stopped your rifamycin therapy. Another question that I see here, Thomas, is that the question says, will sublingual, buccal, or transdermal administration of opioids minimize the interactions with rifamycin because there's no first-pass hepatic metabolism?
Not. I would think there'd be a potential mitigation of that, but still, as it's sort of processed through the system, there is that interaction with buprenorphine, particularly, which is has so many different formats. I think that you'd have to be aware of that and just adjust it based on their clinical response. But I'm not entirely sure.
Yeah. And I see our colleague Dave Ashton has put in a question. Do you think the opioids, which cause a decrease in the rifamycin levels, is responsible for the increase of TB treatment failure among the patients you mentioned earlier?
Just from the articles and stuff, it seems, although that certainly could be a potential component, but a lot of it seems to do with the other social circumstances they have, treatment interruptions, lack of compliance, inability to kind of follow the strict and standard protocols that we've seen. Certainly would be multifactorial, and I think it does get to the point that I think that we're more and more learning of how important it is to follow drug levels. And certainly if we have concern about anybody and they're taking other drugs that could affect the drug levels of our TB drugs, there's just really no reason not to pursue that, because the payout is so much, it's just so great when we understand that we're not getting adequate drug levels in there. So I think that's a real potential component.
Yeah, thank you. And GC Michelle Burton has written a comment. It's my understanding the rifamycins induced opioids causing potential withdrawals. I didn't realize opioids had the potential to induce metabolism of rifamycins. And I just wanted to clarify, I think it potentially more so with the rifabutin becomes induced itself somewhat, less so with rifampin, and probably less so with rifapentine, which is more like rifampin. Any thoughts on that? Did I answer that correctly?
No, I think you're exactly correct.
Okay, great. I don't see any more questions. We've got a few more minutes. If anyone has additional questions, go ahead and type them in. Thomas, I think that one thing that we may all be dealing with more and more is the use of naloxone, as you mentioned, sort of as a good Samaritan or just in a clinic setting. Could you maybe walk through what it might look like if you had a patient who came in and you happened to be unlucky that at the time they were there in front of you, or if you went to, if a nurse went to their home and did DOT and found the patient had overdosed, and in the short term while waiting for 911, what would it look like to administer naloxone? Any thoughts on that or tips on that? Just kind of ease people's discomfort with that practice.
Yeah, you bet. So the most common and easiest way to do is intranasal. So if you find somebody down and you have available the naloxone, students always look at the product first, but it's almost like a little, like an Afrin spray bottle or something. So you would just do it, and you would spray it in their nose, and after about 30 seconds or so, there's a little bit of a time lag, right, for it to get in their system, and it will displace the opioid from the mu receptor, such that you don't have that respiratory suppression. You can't hurt anybody by doing it, and that, I think some people are worried about using medication if you don't know why they're down. Like if someone's down and you think it might be hypoglycemia or some other, or seizure or something like that, you're not going to hurt them by using naloxone. And certainly it's a great first pass. Just assess the person, give them naloxone, do whatever else you're going to do, 911 and all that kind of stuff, CPR is needed, and they're going to benefit or they're not going to benefit from it. But it can be pretty remarkable within a minute, someone going from, unresponsive, on the way out to, pretty much alert and almost normal again, although typically confused and hurting because you've really reversed their opioids rather rapidly.
Yeah, thank you so much for reiterating that there's really no downside to trying to use it, because I think, that would be certainly angst producing. Talk a little bit about, just in the last few minutes that we have, how do you screen your patients for opioid use when, when they're not disclosing that they are using that, and you have suspicion, given that it's now so common, it's probably almost all your patients that you want to at least be aware of, because even as you mentioned, white men with potentially no other concerns may be using it for medicinal reason, or any patient could be and had developed an addiction. Just perhaps briefly cover that.
Yeah, it can be hard to know, right? Because people will hide things. Certainly if they're getting it through a prescription mechanism, the PDMPs can be a mechanism to see what they're taking if they haven't disclosed that as one of their regular medications. Other things, I think a lot of times clinicians and TB nurses are very insightful about people who act strange, and a lot of times will act in an abnormal way. So sometimes kind of follow your gut to be worried about that. And then just like the other day, I had a patient in clinic and I was looking at him, and he had needle tracks up and down his arm. And so we knew immediately he was abusing. So, using some of your physical exam tools to, figure out, what's going on with them. But sometimes you won't know, and you'll just have to be prepared if there are, unexpected bumps in the road because they're surreptitiously using opioids.
Mm-hmm. Do you see a role for using urine drug screens to detect this in patients who aren't disclosing their opioid use? Yeah,
I think if there's a concern at all, I think that's a fantastic thing to do. Certainly, it gets kind of dicey in the sense if you're trying to engender trust in people who maybe not trust the healthcare, the public health system, and so. But if there are people who think that they might be abusing opioids, that's a great way to figure it out. And the urine drug screens can be extremely inexpensive, like $2 to $5 a piece, that do some of the first level screens. Although if you do that, there's about a 4% or so false positive rate. So understand that you might need to do additional testing.
Yeah, great, thank you. I've got a couple more questions. Before I ask these questions, I just want to let you all know we're so grateful that you attended this webinar and hope that you will continue to participate in this series. Our next webinar is going to be a month from now. I believe that it's October the 18th, and we're going to be talking about TB and homelessness. After that, we'll have several webinars that talk about tuberculosis among immigrants and refugees that we'll be doing in partnership with CDC. We're really excited about those. So please keep an eye out for our announcements. And Thomas, I see a question that's saying, what would you like surveillance and data at health departments to do to help support these efforts with addressing the opioid epidemic?
Yeah, there's a lot of things that can be done from a surveillance perspective, and it's really important to use the data sources that are available. CDC is trying to invest a lot into different mechanisms, including using surveillance data from PDMPs, looking at your trends, who's using what. One of the things that seems to be a big gap is using it to help inform physician practice. It seems like we do have some physician outliers who are using really high doses and distributing a lot of opioids, still kind of stuck in the old mindset, particularly when it comes to using opioids for acute pain, chronic non-cancer pain, or using for an acute issue more than 3 days or so. And those are huge issues because we're putting the things out there. We also are looking at using other surveillance mechanisms such as BioSense, which basically is a data feed from ER records, chief complaint and stuff, and that's a good way for us to track overdoses. So there are great things that health departments can do, and if we can kind of give a feedback loop, and that's something that has been explored, basically where you can notify physicians if their patients have overdosed or if they've done something wrong to kind of close the loop. Because if you think about our provider practice, that 15-minute time block, you do everything, you send them, and they go home, and you have no visualization of what's going on with them except for when they come back. And for us to really understand what's going on from a provider perspective, we kind of got ourselves in this mess, and we got to at least lead the charge as far as like pulling back on the flow problem. But we're still going to have a ton of trouble with the people already addicted, and then trying to get docs using surveillance data, using whatever data we can to get doctors to understand the importance of using medication-assisted therapy. There's going to be a huge demand for this. It can be hugely successful in helping certain individuals. And so having our provider community being willing to take on that process too would be fantastic for public health.
That's great. Yes, thank you. I'm looking at a comment. Let's see. Thank you for making some distinction between medical use of opioids and illicit street drug use. It might be helpful to strengthen that distinction a bit, as the presentation does blur that we're getting only medical use examples, but then swing to what street drug indicators and risk factors are there. It's important in the political climate. It's not an us versus them way. That due to the fact that chronic contractile pain patients on opioid therapy are often painted with a brush of addicts and discriminated against, I can see that could be a real challenge with trying to build a relationship with your patient and manage them over time. So I don't know if you have any thoughts on that. It's really more of a comment than a question.
It's really tough, and there's a lot of gray, and it's really easy now. We're all in the pendulum swings, right? And so now everyone's against, at least a lot of the policy stuff's against using opioids, but some people really need them. And so there's some patients who will benefit from them. There are some patients who have a combination of dependency and pain. It doesn't mean that they're really addicts, but there is the chemical physiology of opioids that by their nature will eventually you'll be dependent, without fail. But yeah, there is some variability, and certainly, and even among people who are abusers, IV drug abusers, even the people who are the most manipulative, we still have a charge to serve them and to maintain their relationships. And those are the people who need our help more than anybody else.
Yeah. Going back to your patient, you mentioned that he did really well not taking opioid therapy the time while he was still contagious. And, I understand that you can't really control him going to the primary care, but could you talk a little bit about, once he's off, how you might work how we might work in public health with primary care to say, hey, this patient's been doing really well off drugs. How might we work together to help others realize that these patients were fine, even though the patient's going back asking for it, they may not actually need it. Does that make sense? Yeah, no, that's a great point. And probably we could have done, I didn't realize that he even went back and got it, to be quite honest. I hope it's kind of too late by the time you find out. I thought that he was going to move on without it. But yeah, maintaining close communications with the primary care docs or pain docs is very important. Primary care physicians will be a little bit easier, I think, because a lot of times they'll have a more holistic view, and the pain doctors might not be quite as easy, but certainly, they're good, thoughtful physicians too. So, maintaining those communications would be very important. And then I think we're all learning as a medical community what's going to happen. I think it's just now sort of like coming out of the haze that yes, people can come off opioids and they're not going to be in this chronic horrific pain that we think they're going to be in. Some people, we won't be able to do, but there is a clear sort of arms race that goes on with your pain and your perception of pain with the more opioids you use, and us understanding that, and also too having those conversations with our clinical partners will help us get folks off of stuff that maybe isn't beneficial. Yeah. I'll just say I am always amazed by our public health nurses and how much time they spend with our patients each week doing DOT, the relationships they build, and how they are able to accomplish so much. And spending all the time with these patients, they may be another mechanism by which they can educate patients and help support them if they are willing to stay off medications. Maybe we can tie in incentives and enablers while they're still on TB medicines to help keep them off opioids. I'm not sure if that's done, but if we're using them each week, giving an incentive to come in to take TB meds, perhaps something special mention could be made. Hey, it's another week you've been off therapy for your opioids. That's really fantastic, and just that support and education.
And I think there has been a benefit from public education campaigns about the dangers of opioids. And I think as there's less, as there's more understanding among the lay public, it seemed like it's easier and easier for people to come off meds or not get them in the first place, because the dangers are a lot more apparent than I think than they were.
Yeah. Well, we are 10 minutes over. I think our intention was to stay as long as people had questions, but I haven't seen any new questions pop up. And I want to thank you again, Thomas. You did a fantastic job with this really difficult topic. And then again, encourage our participants to continue to join us on these webinars. And we will ultimately have these recorded, and they'll be available on the SMTC website. We'll let you know when that product has been developed and is available to you. You'll be getting a